Hello, hi, this is Dr. Erica. Thank you for joining me on this particular video. I'm going to give some updates about the new heart failure guidelines for 2022, starting February 1st of this year. There were new lines that stated that more medication amendments have been in place based upon the latest research and also analysis and data that have come in. So I do want to go over some of that material. So stay tuned to the end of the video. Also like, share, and subscribe. Family, friends, loved ones, let them know about this channel. This channel has educational material for medical students, pharmacy students, those patients out there who want to know more about their medications, how to use medications properly, how to go along their health disease state as well, and just need some encouragement throughout. So I have different playlists that involves different videos that are very helpful. And I do hope that you sincerely take these videos into consideration, and please subscribe as well. So I'm going to talk about, in particular, medications that are used for heart failure. When a patient comes into the emergency room, they're experiencing chest pains, things like that, and they may already have uh, been diagnosed with heart failure, and they may have an exacerbation or a recurrence or a relapse. In that case, they already have medications on board. They'll receive IV treatment for pain. They'll receive anticoagulation medication if they have certain ejection fractions, things like that, if they qualify. They also receive aspirin therapy as well. And then they'll receive, again, additional pain medications to be placed on board. And if so, other medications will be added to the regimen, such as your digoxin, your hydralazine, or APRESOLINE as well. And then those medications can be added on if a patient is found to have increased fluids, increased structural changes, and that sort. So we want to ultimately reduce symptoms of heart failure. That is our ultimate goal for treating heart failure: reduce symptoms and prolong life, and good quality of life at that. So that's why we utilize these guidelines. So I'm going to give an overview of heart failure symptoms. There's 4 classifications. The first classification is that the patient does not have any symptoms of the heart failure when they're doing their daily living, when they're exercising. There's no type of symptoms felt. And then also there's no fatigue. There's no shortness of breath. They can perform activities throughout their day as normal. And then the second class is that the patient may have some slight limitations in their daily activity. They might have some actual fatigue or dyspnea is what they call it. They might feel a little headache, a little tired, doing little things around the home. Okay, for class 3, the patient is marked with limitation. They only feel rest at or comfort when they're at rest. And that's it. They don't feel rest when they're doing their activities. They feel like it's a struggle when they do their daily activity. The only time they feel rest is when, or feel comfort is when they're actually either lying down and can only move with limitations. Okay. So, and then the class 4 is the last class of symptoms, and that patient does not have any comfort at all. The patient cannot do any type of daily living activities. They can't do anything except either get ready to go to the emergency room at this point, because there's just no relief, especially when they're actually trying to carry out physical activity. No exercise is performed. And again, there is strict limitations at this point. So with the new guidelines, medications are still in place. There are a few changes that I want to go over with you in this video, so stay tuned to the end. And then if you haven't subscribed, please go ahead and subscribe at this point and be a member of this channel. Now, patients who are, according to the guidelines, patients who come into the hospital and they need to have fluid reduced or edema reduced from their lower extremities, or they just have fluid overload, and it's causing their heart to have diastolic or systolic dysfunction, then the patient should be started on a loop diuretic, not the thiazide diuretic. Thiazide diuretics are no longer first choice. Loop diuretics, according to the new guidelines, should be used first. And this order is in use because the loop diuretic is found to be more potent, more diuresis is performed, and the patient can be stabilized on moderate and high doses. Now, there's still some sort of symptomatic overload at this point, then a thiazide diuretic can be added to the loop diuretic. And that loop diuretic is usually going to be like a furosemide 20 milligram or 40 milligram given once or twice a day. And then also the bumetinide can be given at 1 milligram twice a day as well to get that therapeutic goal met. Okay. Also, the valsartan and sacubitril combination medication, also known as ENTRESTO. ENTRESTO is a medication that involves blood pressure medication, ACE inhibitor, and a new class of medication as well. In combination, they work together, and they are found to be first choice. Instead of using an ACE inhibitor first, we're going to use this combination first instead. So do be mindful of that. Now, the rationale behind that is that patients are going to have an increased benefit of cardiac remodeling, and they have a decrease in the cardio biomarkers as well. All these medications will decrease mortality, so that is a plus. So we do want to keep that in mind. Only time we're going to use the ACE inhibitor instead first is when these medications are intolerable. So if the combination medication ENTRESTO that I mentioned is not tolerable, then we're going to start the patient on an ACE inhibitor instead. That's the only time we'll use an ACE inhibitor or an ARB in place of the combination ENTRESTO. But ENTRESTO is, again, it's a ARB plus it is a new medication that has been recently introduced into the market here recently. And these medications are found to be highly economical, valued, so that is a plus as well. So the medications that I'm mentioning are economically valued, and so they are, again, placed at high choice because of these values. And then the beta blockers. The new beta blockers for all current and previous symptom patients should be on board to decrease death and hospitalization and also relapse. And that includes your carvedilol, your bisoprolol, and your metoprolol that I mentioned in other videos. These are the beta blockers that are known to reduce death. And because they reduce death, they are going to be utilized automatically in case the patient does have heart failure symptoms or not. They should be placed on a beta blocker, okay? And again, these medications are known to reduce mortality and hospitalization relapse. So we do want to place carvedilol or bisoprolol or metoprolol on board to control heart rate and heart rhythm as well. Okay, then the mineral corticosteroid aldosterone antagonist that I mentioned, it does not cause side effect of gynecomastia that is known for corticosteroid receptor agonists. So this particular class of medication includes spironolactone, and it does not have that side effect. So do be aware of that if you're taking the medication. And then the medication is known to decrease death, hospitalization, heart failure, and also sudden death due to a systolic dysfunction. So do make note of that. And the patient has to have good renal function as well. It does have a side effect of working in the kidneys. That's one of its other mechanisms of action, is that it's going to help with flushing or being a diuretic as well. And if that medication is utilized in a patient who has kidney failure, then that medication can cause side effects of increased potassium and also renal dysfunctioning. So renal functioning is very very important with the spironolactone class of medications. So do be aware of that. The patient should have their serum creatinine monitored, and the renal functional baseline and throughout use should be also monitored as well. Okay, so moving on to the sodium glucose transporter inhibitor receptor for diabetes. This medication should be implemented if the patient does have diabetes or they don't have diabetes. So that's new. The patient should be continued use to decrease the relapse rate, and also those patients who have left ventricular dysfunctioning can take this medication. It's best to take medication in the morning as well for best effect. And there's two particular ones in this particular class that are recommended, and that includes the empagliflozine and the dapagliflozine as well. Those are the only two out of the group of medications in this class that's recommended because they have been found to help patients who have systolic dysfunctioning, and empagliflozine has been found to have an effect on those who have a dystolic or preserved dystolic malfunctioning in their heart as well. So empagliflozine should be started as well. And again, it doesn't matter whether the patient has diabetes or they don't have diabetes. They should take this medication just like they would take the beta blocker that I mentioned earlier. Those two classes are mandatory according to the new guideline. I'll go over isosorbide and hydralazine. They should be used in combination. They are phosphodiesterase 3 inhibitors, which means that they're going to dilate the arteries, cause an increase in flushing of the blood system. This should be used in African American patients, those who come from African descent. Those patients qualify for both of these medications, the APRESOLINE and the isosorbide. And it should be used as a last line when the patient has been optimized on all other medications, but they're still presenting with symptoms. Okay, so be mindful that this particular combination of drugs should be used in African Americans who have not received a symptom relief. Okay, the best effect when already on digoxin and diuretic will this class of populations receive that benefit. Okay, so the next group of medications that the guidelines talk about is going to be digoxin and also a medication called vericiguat. I can't say it. Vericiguat, which is selective for high-risk cases and recent worsening despite optimal use. So those patients who have been optimized on therapy and still no benefit, they can take this new medication. It's been out on the market since 2021, and it can be utilized, but it has weak recommendations or weak primary resources to say that it can be used. So it should be used as a last line agent for those who have ejection fraction less than 45% and also who have chronic heart failure. So inotropes are variable effects due to mixed data, but they are can be used. They have variable presentations on artery dilation and peripheral resistance, systemic resistance. They all have different effects, but they all have a increased heart rate and cardiac output effect. And that's going to be your dopamine, your phosphodiesterase inhibitor, also your vasopressor, like your epinephrine and your norepinephrine as well. Your milrinone is going to be your phosphodiesterase 3 inhibitor. Now, again, all of these are going to increase heart rate and cardiac output. The milrinone is going to decrease peripheral resistance, which is good. Going to give that give the blood a little bit extra room to flow and present oxygen. Also, epinephrine is going to increase cardiac output as well as have variability on systemic vascular resistance. Now, omega-3 fatty acid is a supplement. This medication is recommended for patients to go home on and it helps to protect the heart, and it is known to decrease fatality and non-fatality in cardiovascular disease. Okay. It is used as adjunct therapy only, but not to be used alone. And it's used for classes 2 through 4. And that stages 3 to 4 or class 2 through 4 symptoms to decrease mortality and hospitalization. Now, there are a couple other medications that I wanted to make mention of, and digoxin I've gone over, vericiguat I've gone over, and again, that medication is the medication that I mentioned that is only used for high-risk cases, those who have worsening symptoms despite optimal use, and they have a pregnancy category of X, so it shouldn't be used in those who are expecting. And it's used for patients who have an ejection fraction of less than 45. Okay, so we do want to recommend that. And this particular video is not all inclusive, so do look at the guidelines. I've gone through the guidelines today to make sure that I got most of the important drugs that are actually mentioned most often during heart failure. Nitroglycerin, they didn't say anything about much about nitroglycerin or NO, nitric oxide. But I do want to make mention that that is a medication that's very important as well. They did actually mention it. Maybe I'll give some updates in the description below for you to take a look at. So please do visit other heart failure videos that I have to get more information about the stages, the classification of symptoms, the use of the pacemaker, also the way that heart failure is being diagnosed. There are over 5,000 or 500,000 cases diagnosed per year. That number has steadily increased, and there's over 5 million people who are affected by heart failure currently. So it's very good to know the history and data behind disease state that you may be dealing with, and the medication therapy as well. And also get to know your pharmacist. Get to know your pharmacist when you're picking up refills on your prescription. Get to know your physician as well, so that you have that relationship on board. Residents, do know who the residents are, the team of cardiologists. Also have a relationship with the nurses staff as well, and keep maybe a diary or journal of your symptoms that you may be feeling. And also let your family know as well. Have a close loved one that you can confide in about your symptoms, about how you're feeling, and monitor your urine output as well. Monitor how often you're urinating. Side effects, you can monitor for headaches, monitor for a heart palpitation, or monitor for heart arrhythmia as well. And also, I want to recommend, if you're a tobacco user or a nicotine user, do cease from using those products, because they do cause heart failure and atherosclerosis. Also, if you're able to avoid liquids, increase fluid intake, do be aware of that. Minimize your fluid intake. Eat nutritious diet as well. That will help overall and give you better health. And so that's my recommendation as Dr. Pharmacy. And I hope you like, share, and subscribe. And thank you for joining me on this particular video. This has been an update to the heart failure guidelines. And I hope to see you on the next video. Please like, share, and subscribe. Thank you for joining me. Signing off, Dr. Erica. Bye-bye.